measure of intelligence is the ability to change. Albert Einstein. Good afternoon, everyone. My name is Kirtan Patel, and welcome to ADHD Disparities in Diagnosis and Treatment. I am a student that is an ADHD advocate and is deeply passionate about neuroscience and psychology, and has experienced firsthand how uneven, biased, and delayed factors can contribute to a neurodivergent life. I want to begin with a short story. Imagine two brothers. Both have ADHD and are impulsive but curious as well. One grows up in a school where they provide accommodations he needs for success and identify his ADHD early, while the other one grows up in a school where they do not notice his ADHD and dismiss him as lazy, unmotivated, and most importantly, disruptive. Their outcomes are nothing alike, not due to biology, but because of access. The difference here was potential overlooked versus potential recognized, and that is exactly why we are here today. ADHD is often described as a neurodevelopmental condition, and it is. Clinically, it is defined as a disorder of brain development that affects attention regulation, impulse control, emotional regulation, and executive functioning. It is rooted in differences in neurocircuitry, particularly involving the prefrontal cortex and dopamine pathways, and it persists across the lifespan. But diagnosis and treatment do not occur in a vacuum. They occur in schools, families, clinics, cultures, and different workspaces. Who gets recognized early and who gets labeled as lazy, disruptive, and unmotivated? Who gains evidence-based care and who gets left, who falls through the cracks? Globally, ADHD diagnosis rates vary dramatically, not because ADHD is common, but because recognition, stigma, resources, and cultural interpretations differ. In the US, ADHD diagnosis rates are relatively high due to school referral systems and access to specialists. Yet children of color, girls, and students from low-income families are still often underdiagnosed or misdiagnosed. In many European countries, diagnosis rates are lower, reflecting stricter criteria, conservative attitudes toward medication, and greater reliance on psychosocial expectations. Across much of the global south, ADHD remains under-recognized due to limited access to care, cultural stigma, and insufficient trained clinicians. These disparities shape academic outcomes, mental health, economic mobility, and self-worth. Today's panel brings together three leaders who work at critical points in the system: clinical psychiatry, school-based mental health, and community and education psychology. Allow me to introduce Dr. Glenn Elliott, whose decades of experience in clinical psychiatry and ADHD research illuminate how diagnosis and treatment have evolved. He has taught at both Stanford University and UC San Francisco. Next, allow me to introduce Dr. Laura Turner-Esel from Stanford University, whose dedication to neuroscience, education, and belonging-focused programs shows how community and identity shape ADHD pathways. And finally, allow me to introduce Dr. Lineca Jones, a PhD in psychology, whose school-based expertise revealed the real-world barriers and opportunities for equity in kindergarten to 12th grade systems. Thank you all for your time, your commitment to equity, and most of all, your willingness to share your expertise with the world. I also want to thank the Learning Planet Institute for creating and stewarding a truly global space for dialogue, equity, and innovation in education and human development. It is an honor to be part of the Learning Planet Festival, an initiative proudly sponsored by UNESCO and rooted in a shared commitment to reimagine learning across cultures, disciplines, and borders. The festival's international reach and emphasis on lifelong, inclusive education make it a uniquely powerful platform for conversations that demand both global perspective and local action. I'm especially grateful for the opportunity to participate as a Learning Planet Youth Fellow. This fellowship represents more than recognition. It reflects a deep investment in youth leadership, intergenerational collaboration, and the belief that young advocates can meaningfully contribute to shaping educational and mental health systems worldwide. Being associated with Learning Planet has reinforced me that advocacy does not end at national borders. The challenges we are discussing today around ADHD, access, stigma, and equity are global challenges, and they require global dialogue, shared responsibility, and collective action. So for my first question, I want to ask all three of my panelists, starting with Dr. Elliott. How do you define disparities in ADHD when we consider diagnosis, treatment access, and long-term outcomes across the lifespan in the US or globally?
Certainly, many of the points you hit on, I completely agree with. I think what you left out is the temptation to sometimes overdiagnose ADHD as well as underdiagnose it. That actually tends to be upper middle class individuals whose children are not performing as well as the parents believe they should or could be, and there's a temptation to blame that on lack of attention, which complicates the situation sometimes as well. Also, as you said, there's even within the United States, both across different regions and even within the same region, there are huge disparities in the degree to which ADHD gets diagnosed. Part of the problem there is we don't have a nice objective biologic way of measuring who has ADHD or who doesn't. This is still what we call a clinical diagnosis. It's based on reported signs or symptoms. So if parents, as you said, attribute this, or schools attribute this to lack of motivation, laziness, lack of interest, then they just may not see it as a fixable problem or the need for a diagnosis, which it makes it really difficult. I did a study some years ago within a large HMO system within the Bay, actually all of Northern California, 26 different pediatric clinics within the same organization, and the rates of diagnosis of ADHD varied from 1 to 6%, depending on the clinic. In terms of, you mentioned disparity between girls and boys. There are differences, although there are girls who look very much like boys in terms of their symptom presentation. Girls often have more of the inattentive kinds of issues, and they are much less likely to sort of come to the attention of the teacher because they're not causing any difficulties. So they often get missed. And inattention kinds of issues tend to become problems academically later, like 5th and 6th grade. So, and fortunately, our diagnostic manuals have finally sort of caught up with that, which took a while to realize that there's a group of people who may not get diagnosed, not because they don't have the disorder, but because it hasn't begun to interfere with them. So what we're really looking for is, in some ways, what you described very nicely with your two examples, there's going to be a mismatch between expectations and the individual's ability to meet those expectations. That's true at home as well as at school. If you've got a chaotic family, they may feel like their child is just part of who they are. And we know ADHD is an inherited disorder, so it's not unlikely that one or both of the parents may have some symptoms of ADHD as well. So they may not see it as a problem, just as an active, boisterous young man or young lady. And similarly with the schools. So, and then there's the issue of who actually makes the diagnosis. Most ADHD diagnoses are made by pediatricians who are unfortunately not typically well trained to make that diagnosis. So it often, and they have very little time to do the kind of assessment that's needed.
Okay, thank you for that amazing answer, Dr. Elliott. Now I would like to ask Dr. Easel to bring your input to the table.
Yeah, thank you. I think that, Dr. Elliott made some really good points just in terms of how I think about, because you asked about the definition, how we define disparities. I just think of that as unequal distribution of those things that you mentioned, diagnosis, treatment access, long-term outcomes, again, across different demographic groups. And so Dr. Elliott mentioned the gender disparities that we see with more frequent diagnosis in boys compared to girls, and some of the reasons for that. We also see racial ethnic disparities. And so here in the US, children from certain racial minority groups like African American and Latino children are less likely to be diagnosed. And that can be influenced by a number of different factors. We think about cultural differences, also bias in the diagnostic process, because as Dr. Elliott mentioned, it can be somewhat subjective. It's not as tied to biological markers as some might think it is. And then systemic things like an access to healthcare services also play a role in diagnosis. And so, of course, we also know that socioeconomic disparities exist. And so children from lower socioeconomic backgrounds might be either underdiagnosed or overdiagnosed.
Right.
The underdiagnosis due to, like I mentioned, limited access to healthcare, but overdiagnosis can happen in context where disruptive behavior in the classroom, for instance, is quickly attributed to ADHD without a thorough evaluation or an assessment. And so there's just kind of an assumption there that that's the case. And treatment access, again, disparities in healthcare is something that we've only seen, get exacerbated in recent years, and that significantly impacts the treatment of ADHD for individuals, especially those from lower socioeconomic backgrounds or even rural areas. So geography can play a role in how people have access to specialized healthcare providers. People can end up with untreated or just poorly managed ADHD because they don't have that access. Things like insurance coverage obviously play a role. Inadequate coverage means that you might not be able to access medication or the proper therapies or other interventions that would be helpful. The thing that I think often gets missed or maybe not talked about enough is the issue of cultural competency. I think that some of our disparities in treatment across different groups can actually be attributed to lack of awareness or appreciation on the part of some of our healthcare providers about the diversity of the backgrounds that people come to us with and the different ways that their symptoms might show up or the different ways that they need to be addressed because of, just their cultural, spiritual, or otherwise, kind of environmental backgrounds, and that can really affect how they engage in the treatment and the kind of rapport that we're able to build with them to help them adhere to some of our treatment goals. And so, and as Dr. Elliott mentioned, this has all types of long-term outcomes for people, some really high stakes ones. We see disparities in educational attainment, obviously, because if, there are these differences in diagnosis and treatment, then children who don't have appropriate interventions can struggle academically. We might not be able to retain them in our school systems. They have lower educational attainment. That leads to long-term effects on employment, financial stability, mental health in general, because we know these things are also tied to other conditions, mental health conditions, like namely depression and anxiety. So there's often a co-occurrence with ADHD and those conditions. And then criminal justice involvement is a huge one. I think individuals with untreated ADHD are often at higher risk of involvement with the criminal justice system. And that's only exacerbated by other disparities like socioeconomic and racial disparities across our systems. And so we see certain demographic groups with higher rates of incarceration. And so I just think that all of these things speak to some of the systemic and kind of bigger, larger scale biases within our healthcare system.
I appreciate the candid answer, Dr. Isel. Now I'd like to take the question to Dr. Jones.
Well, all the good things have been said, so I agree with both what they were saying. Absolutely. For me, working in the schools, I definitely agree with Dr. Elliott as far as the diagnoses with pediatricians versus psychologists. Here in Texas, we are not able, like as a school psychologist, we're not able to diagnose. We just find eligibility. But my testing is way more thorough than anything that a pediatrician does. The pediatrician sends a Vanderbilt and sees the kid for a few minutes while we're doing extensive testing. However, it is not looked at here. So what I'd have to do is I'd have to do the evaluation and then send it to the pediatrician for them to look at. So I definitely agree with that. And then definitely like Dr. Essel was saying, like you just see certain groups being looked at. I'll say honestly, in the schools, what I see often is that the Black and brown children, they're looked at as maybe having an emotional disability first instead of ADHD, because they forget that component of the emotional dysregulation that's a part of ADHD, and they go straight to that ED label, which is it's not a great label because people look at it in a certain way. So I see a lot of that, and then also I do some work in private practice, and the same thing. We're seeing a lot of young women and women in their 20s and 30s who have never been diagnosed, and they've been wondering their whole life, what is going on, and come to find out they've had ADHD, but because it didn't look like what people think ADHD looks like, they went through the cracks. So they've, gone all these years not being diagnosed, and we see that it's impacting people in their careers and in their jobs and their family life, and they just kind of don't know what's going on. So sometimes it's just really just getting an answer, just having an understanding of yourself. So.
Thank you, Dr. Jones. Now I would like to go into cultural and racial dimensions. For my first question, I would like to ask this one to Dr. Elliott. Over the course of your career, how have changes in diagnostic criteria and clinical thresholds interacted with race, class, and gender? Have some populations been systemically underdiagnosed or misdiagnosed in the US or globally?
Not only have, but to continue to be. But starting with the US, so I've been in the field since 1984. And during that time, we've had 3 different versions of what we call our diagnostic manual. And for a long time, the main focus was on white young males, 6 to 10, basically. And most of the diagnostic criteria were abstracted from studies of that group of people. So it didn't look at issues of culture at all. And largely girls were underrepresented in the studies. And the so-called inattentive ADHD, which is one that girls are actually probably it's 50-50 in terms of boys and girls in that diagnostic group. They just didn't get picked up because that's not where the studies were. So we've been through 3 different versions. The first one is sort of an embarrassment when one looks back on it, because it was based on essentially 12 criteria, which up front in the manual, they said none of these are specific for ADHD. These are just symptoms that we've noticed. And you had to have 8 out of the 12 criteria to make the diagnosis. And they did recognize that there were some people who weren't hyperactive, but it was really an understudied group for a long time. And there was very little studies across cultures as well, and across different regions of the United States. As Dr. Essel already pointed out, one of the interesting things from my point of view, particularly with Black individuals, is that depending on the state, they really are likely to be either over or underdiagnosed. based on a variety of political pressures, primarily. I just am reviewing a study out of Japan where ADHD is actually lower than it is in other places, and we believe that's not just inattention or lack of sort of awareness, but because the school system is so much different. It's so much more highly structured and provides a structural environment that probably helps reduce ADHD symptoms, and therefore the diagnosis is less likely to get made. Also, Europe, for a number of years, has consistently resisted particularly the idea of treatable ADHD, and thought of as it is mostly what Dr. Russ talked about as emotional disturbance, that it was a problem in parenting. So those discrepancies have begun to commingle and merge into a more of a consensus, but again, even just within the United States, we're not really great at having people available who are expert at making the diagnosis and providing treatment. And there's also a whole, I mean, getting the diagnosis is difficult, but in addition to that, there's the issue of treatment. There's a real stigma, and again, that's somewhat culturally based. Asian families, Black families, not so much Hispanic families in my experience, are very reluctant to think about treatment for ADHD, even if they believe their child has it. And there's a tendency to, again, believe if just the parenting changes, then that'll make things better. And that could be a difficult hurdle to overcome. So there have been changes. The other huge change is that up until I would say the mid-1980s, the recognition that ADHD didn't stop with puberty was simply not there. The belief was that ADHD magically disappeared once people hit puberty. And it took some excellent research first to sort of realize that it showed, although it varies and it differs in terms of symptoms, that it continues well into adolescence. And then actually now we know that for a significant part of the population, it continues into adulthood and probably throughout life. And that's a huge difference in our understanding of the disorder. So we went from something that was viewed as a childhood disorder that you pick up usually at 4 or 5 or 6, and basically school-based, up through puberty, and then magically it went away. What mostly goes away is the hyperactivity, but the impulsivity and the inattentional issues, and certainly the other things that are related to it, like executive functioning kind of activities, are still there and very much impede optimal functioning. So we have made progress there, I think, although there's still resistance around, in many areas, around diagnosing ADHD in adults. And depending on what region of the country you're in, finding somebody who'll even consider trying to diagnose you at that age is difficult, and certainly getting treatment for it may be impossible.
Thank you for that answer, Dr. Elliott. I would like to ask the following question to Dr. Jones now. In school settings, how do cultural stigma, implicit bias, or family mistrust of institutions affect which students are referred or not referred for ADHD evaluation in the US or globally?
Yeah, so I would say definitely in the schools, What I found with the parents, sometimes parents come in and they think that we're just trying to get their children medicated. They're very against any type of issue because they might think that it's saying something about their parenting style or that they're doing something wrong or that they did something. I also see times where people are like, as far as ADHD, that's not real. That child just has behavior issues. They could just, be parented out of it, disciplined out of it, I would say. I see a lot of that. Also, I think just overall, I think what I kind of touched on earlier, just the way it is looked at, looking at Black and brown children versus white children. You might hear more terminology with the Black or brown children of, they're more aggressive, they're more behavioral issues, where with the white student, you might hear something like, oh, he just needs a little more support, or, you just hear maybe a little more of the negative terminology. And then the same thing with the girls, we see the same thing, like, the girls are, they might say more anxiety. We see more anxiety, whereas like, it's not ADHD, it's more anxiety. So things like that. And again, like I said, just in doing what I do, a lot of times there's a lot of pushback because people don't want the label. They just think you want to label my child and this is going to be something negative that they have to go through, or they're just seeing it as something negative. So that's what I see a lot of times in the schools.
Yes, absolutely. You should never be ashamed of your ADHD. It's just a difference, not a pushback. For my
Absolutely.
next question, I would like to ask it to Dr. Isel. Based on your work and the podcast episode I had with you on my channel back in the summer, how do cultural and racial barriers influence ADHD diagnosis and treatment within neurodivergent communities in the US or globally?
Yeah, I think a lot of different ways, and I think that all three of you have actually spoken to a major one, which is cultural perceptions and stigma. I think that's a big barrier. There might be cultural beliefs in different communities about mental health and neurodivergence, and that can lead to stigma. As Dr. Jones mentioned, a reluctance to seek diagnosis and treatment. In some cultures, ADHD symptoms are misunderstood or just dismissed as like behavioral problems rather than recognizing them as part of a neurodevelopmental condition. Um, and, all of this leads to like a lack of awareness, a lack of advocacy within certain communities, and that means fewer resources and support systems for neurodivergent individuals. I think the flip side of that is there are just in the world, there's historical and ongoing ethical breaches that we know about and many that we don't in healthcare that contribute to, for some communities, a very valid sense of mistrust. And I think that distrust can also deter families from seeking help. It can keep them from adhering to whatever treatments there are prescribed because there might be fear, there might be bias, but they're also just trying to protect themselves from abuse and discrimination because they're very aware that those things are real. And so I think that, that's just a reality that we have to be honest about as well. I think, as I mentioned earlier, some of the cultural and racial barriers have to do with lack of cultural competency amongst providers. And so healthcare providers, again, might just not have adequate training or adequate understanding or respect for clients' lives and for young people's realities and environments that they're in. And so they might apply diagnostic criteria or assessment tools that are not culturally sensitive, that can all lead to underdiagnosis, inappropriate treatment choices that don't take into account the patient's worldview and the way things are understood or done in their family, their neighborhood, their community. Um, Language barriers are a really obvious source of disconnect, which hinders diagnosis and treatment because patients with limited proficiency in the dominant language in an area will obviously face difficulty accessing information, communicating their symptoms to their provider, understanding the medical advice that they're given. I think providers that don't speak multiple languages or agencies that don't provide interpretive services or try to offer written materials in multiple languages are going to be less helpful for people, especially in a diverse environment. And then again, socioeconomic factors play a role because, again, the healthcare access, the access to services, if there's less of that, that means individuals from lower socioeconomic backgrounds have limited access to diagnostic evaluations, professionals, necessary treatments, and all of that contributes to the disparities that we see. So I think that those are the critical ways that I see some of those cultural barriers influencing things.
Thank you, Dr. Isol. For my next question, I would like to ask Dr. Jones, from your perspective inside kindergarten to 12th grade systems, how do early gaps in diagnosis or accommodation follow students into adolescence and adulthood, including workforce readiness and mental health outcomes in the US or globally?
Yeah, definitely. I think especially when it's not identified, we definitely see children who might have difficulty with those executive functioning skills that we need, like the planning. Just going into the schools, like I actually work in a middle school and a high school, and it's really like it's mind blowing how many students are in high school who are just now being identified. So they've gone through all of these years of school having these issues and not been identified whatsoever. And that can be very challenging. I mean, like I said earlier, we are seeing a lot of, especially women coming in, who had never been identified. And so you can just see how that has impacted them. Like there are certain skills that they didn't know that they needed to further develop because they're probably thinking there's just something wrong, not knowing that, they have these executive functioning skills that they needed to build up on. So you can see how that impacts people just all across. I mean, in every aspect of your life, whether it be additional schooling, whether it be your career, your family. I mean, trying to keep things organized for your family, things like that. So I definitely think that if it's not seen early, caught early, so you can go ahead and start, intervening and having those interventions, we definitely can see a negative impact as you get older, just all across the board.
Yeah, unfortunately, that has happened in my family in the past. My grandfather went almost his whole life without knowing he had ADHD and wasn't diagnosed until in his final years. And my father went his entire school and wasn't diagnosed until he was in college. So that was very hard for both of them. And I feel that's very important to be diagnosed early. And lucky for me, I was very fortunate to have parents that were able to see it. So I was able to cope with it much better. And speaking of which, Dr. Isol, how can educational systems intentionally prepare neurodivergent youth, particularly those from under-resourced backgrounds, for transitions into higher education, employment, and adult life?
I think there are a ton of ways, really good ways. There's a lot of points of intervention there. I think the thing that jumps out at me the most is being able to enhance student self-efficacy, using like a strength-based model, individualized supports for students. And so shifting away from, looking at deficits and looking at strengths. We at Stanford in the Neurodiversity Project, we advocate a lot for universal design for learning. That provides a lot of flexible ways to access content for students to demonstrate their learning and engage with the materials. And then things like individualized transition planning, so that can start early around age 14 or 16, and that includes helping students to look at their career interests, work on self-advocacy, looking at post-secondary plans, and then IEPs, individualized education programs, and 504s, those being built collaboratively with the student so that their goals are incorporated into that and their voice is prominent in that. I think that those things are, one strategy that schools can use. And obviously schools are also, or educational programs, even in addition to school, can help students with their executive function and their self-advocacy skills, because those are all things that they're going to need to navigate college and work and adult life independently. And so focusing on things like time management, organization, working memory, these are things that we know many of these students struggle with, but they're critical skills for them to have support on, focus on building, learning to articulate their needs, their preferences, the accommodations that they need in the workplace or in higher education, offering peer mentor programs, so that older neurodivergent students can help model skills and encourage younger students as they're, getting out into the world. Offering things like project-based learning, just helping to make education relevant to real life after school. Things like service learning, job shadowing, workplace tours, things like that. And I think that one of the things that we've specialized in is partnering with employers too. So working on the other side in the community and in the business community to help create more inclusive work environments for students that are coming out. And providing the companies with a skilled workforce, but then also providing them with training in neurodiversity so that they understand the kind of accommodations they need to provide and the communication styles that are most effective in supporting some of these potential employees. And then things like strengths-based placement or customized job creation so that you're tailoring the role to fit the individual strengths of a person. So yeah, these are just some of the partnerships that I think can really help. Just by working together, we can create this web that helps transition students from those educational environments into adult roles, school to work transition, internships, co-ops, things like that, that really help to create a more supportive pipeline for them all the way through.
And also to elaborate on what you said, Dr. Easel, also internally, and you could always remain productive, improve your productivity by using planners and alarms because, yeah, like if you have issues getting up for school in time, you could have snooze alarms. And if you have issues planning your tests and you're studying, use planners. I recommend using planners because that will always make you stay on track and on the same page as your classes.
Yes, absolutely. There are
yeah.
all types of tools.
Yeah.
Can I add in? A lot of this can also be applied to younger kids as well. It mostly needs to be externalized and some of the things that you were just describing, but in encouraging interaction between teachers and parents in a much stronger way than the average child may need can make a huge difference because often kids begin to fail because they, quote, forget, which probably is true, to turn in assignments. So there's nothing more frustrating to a parent of an 8-year-old to have spent several hours one evening getting homework assignments done, and then the child doesn't turn them in the next day. So they don't get credit for that. And that's hard on the kid's ego. It's hard. It makes the parents frustrated, and it makes the teacher believe that the child's not trying. So, and all of that's really low cost. And as you said, we're in a generation now where we've got a lot of electronic tools. Instead of expecting the kid to write down assignments and carry them home, sending an email to the parents of what the assignments are is really not that much more effort and gives the parents a chance to actually be more helpful and contrariwise to make sure that the assignments are actually turned in when they're supposed to be.
I think that's a good point, and I just want to piggyback on that for 1 second because I think that also speaks to we're talking about collaborative efforts, but bringing the families in. I mean, we really have to respect that parents often have a lot of deep insight into, young people's strengths and their needs. And I think that being able to have schools partner with them and have staff that work really closely with parents and families through these different transitional points in a child's life, younger, as Dr. Elliott mentioned, but also as they get older, college applications, workforce programs, things like that. These are places where families, schools, and other support staff can really, really work closely together to create that kind of web of support for the young person.
Thank you for your answer and your elaboration, Dr. Elliott. For my next question, I would like to dive into treatment equity. My following question is for Dr. Elliott. What evidence do we have that access to evidence-based ADHD treatments, behavioral therapy, medication management, and multimodal care is unequal across across communities in the U.S. or globally? What practical steps could meaningfully close those gaps?
Well, we have lots of evidence that there are inequities. It's even worse than inequities. There are biases within the medical profession. There are still physicians who don't believe in ADHD. And if you happen to be the patient of one of those physicians, you're not going to get treatment. For better or worse, the best medications still are stimulants, and there's a lot of stigma around the use of stimulants. One of the things that I experienced was adults who had been diagnosed and treated on the East Coast coming into the Bay Area and discovering that there's a very much smaller group of physicians who are willing to diagnose stimulants for adults in California than in Massachusetts or New York, for example. That comes as a shock to a lot of adults who made that move. My son works for the San Francisco VA and has become kind of an advocate there for diagnosing veterans who've had undiagnosed ADHD, often for years, and actually diagnosing them and treating them. Up to that point, the VA, particularly he works in the substance abuse area, there's been this bias against anybody who's using substance of any sort shouldn't be allowed to use potential substances of abuse, which includes stimulants, even though, in fact, there's good evidence to suggest that appropriate treatment of ADHD reduces the likelihood of other kinds of impulsive substance abuse. But there's also, as Dr. Essel had mentioned, actually, I think both the other speakers have mentioned, there's this parental bias that one has to sometimes overcome as well, of I don't want my kid to be on drugs. There are non-medication interventions. They're much harder to get access to. They have the advantage of not using medication, but the disadvantage is they only work as long as you continue to use them. And there aren't that many people trained in helping people set that up. So if you've got parents who are resistant to using, we're in child psychiatry, I would say ADHD treatment using medications is by far the best studied area in psychopharmacology that we have. Yet despite that, there are people who simply reject all of those studies and believe that kids just are going to outgrow it and they'll be fine. That kind of professional bias really needs to continue to be fought on a regular basis, particularly since pediatricians outnumber non-pediatricians, who are mostly child psychiatrists, who can prescribe medications, outnumber us by about, I think they have like 38,000 people versus about 8,000 child psychiatrists, so in the United States. So there's an organization called REACH, which actually helps to address this kind of issue of trying to educate pediatricians around a variety of disorders, including ADHD, and show them the evidence that we've got that it can be diagnosed relatively objectively and relatively clearly and treated quite successfully if they include that as part of their consideration.
Amazing answer, Dr. Elliott. For our next question, it's for Dr. Jones. What stigma reduction strategies have you seen work effectively in culturally diverse schools or community settings in the US or globally?
I think kind of what we said earlier, like just not looking at it negatively. If we look at the number of people who are neurodivergent, I mean, it's there's way more than not. So I think just not looking at things so negatively, and also just maybe starting more of a like we talk about like tiers, like I don't know, MTSS, like the multi-tier systems, like looking at it like from in the schools, starting at a school based, like we're just looking at executive function because like Dr. Essel said, these are skills that everybody needs anyway. So instead of like singling it out and making it look like it's a negative thing, look at it like we all need these skills. So let's develop them at the younger age, like Dr. Elliott was saying, if we go ahead and start developing it and making it a normal part of what we learn, then we won't see it as such a negative thing, is what I'm thinking.
Yep. You always think of your ADHD as just a difference. It's never it should never be a negativity in your life.
Absolutely.
Okay. For my last category, policy and advocacy, I would like to ask the following questions to all my panelists. Let's start with Dr. Elliott. If you could implement one systemic or policy level change to reduce ADHD related inequities in the US or globally, what would it be?
Probably universal screening, a very brief but universal screening of kids, probably age 6 or 7, probably through the schools because that's where all kids are. That's where they live when they're not at home. With the systems where there's worries about that, to be able to then refer them for more thorough evaluation.
Okay, Dr. Isel?
I would say the same thing. Just implement universal, publicly funded, school-based neurodevelopmental screening and support, and divorce that completely from behavioral discipline practices and tie it directly to services. I think that would do a lot to normalize identification and reduce stigma and bias around it, and then catch ADHD and other conditions early across all demographics.
What about you, Dr. Jones?
Yeah, I mean, I have to agree with what was said. I mean, definitely getting involved. I would say also probably more community and school working together, because I think a lot of times, like I said, like we were saying earlier, like, you know, the school psychologists or the psychologists, they're diagnosing, and then there are differences in what the pediatricians see. And I think if we worked more together, it probably would be a lot, it would help out the students a lot more. And also, again, starting with those executive functioning skills, like learning those things, teaching those things earlier. And I think those things would help a lot.
Thank you all for your amazing answers. And for my final question, we'll start with Dr. Elliott again. What concrete role can youth advocates, parents, educators, and community leaders play in pushing systems toward equity? And how do we mobilize them effectively in the US or globally?
Globally, I'm still not sure. There are so many, even Britain and the United States, which are probably as closely aligned as any of the other countries. There are a lot of differences still that are really fundamentally philosophical in terms of the belief systems about what causes problems. Within the United States, at least, unfortunately, we're in a period right now where it's very difficult to come to any kind of a unified view of the way things ought to be. So I don't know that we have a quick answer. I think collaborations, for example, the Academy of Pediatrics, American Academy of Pediatrics, has done a really wonderful job of helping pediatricians address a variety of issues, including ADHD. And I think collaboration among some of the professional organizations, bringing together our collective knowledge and coming to agreements about what's needed would be a step in the right direction. But it's not going to be easy. I think in terms of private, I think the kind of work that you're doing, at any rate, I think the fact that I think this is an area, and at Stanford, I know they in college now, undergraduate, they have this diversity group that anybody can come to. You don't have to be diverse, but I think recruiting other kids, partly because that also helps to destigmatize the issues that right now tend to separate rather than bring people together.
So, Dr. Jones, what is your answer?
Yeah, I would just say really educating people on what ADHD is, what it looks like, how it can look differently. Definitely empowering those, especially younger students, to advocate for themselves and understand what they need. I think looking at that, the strengths base, looking at it from the strengths base and looking at that area more than the negativity. And I just think just collaboration, like we have to work together, like we all have in different areas, we all have knowledge. So if we do work together and kind of educate one another, I feel like, that would help us out.
Dr. Isel?
Yeah, I love both of those answers. I think just collectively, like reframing, Dr. Jones just said education about what it is. I think reframing neurodivergence as a difference with strengths, not as a personal or cultural failure, and encouraging pride around that. I think we all have our roles to play. Advocates, can model that self-advocacy for neurodivergent individuals. I think parents and families have to kind of demand accountability and a certain kind of continuity of care. Educators, their documentation and their lived experience of working with neurodivergent students is important for us to see what's happening and how it's impacting young people in real time. And community leaders, obviously, like policy and funding are required for us to move forward. I think, working, as Dr. Jones said, across all these different roles and sectors, kind of like a coalition, is what we really need to move the needle. And I think putting the action into local institutions, like we've been talking about, schools, clinics, faith communities, community centers, and those kind of hubs is where we're going to see change really start to take place.
I appreciate all your answers, and personally, I think that the most important thing every individual with ADHD needs to hear is that you're not quote unquote fixing yourself, you're improving yourself, because ADHD is not something you need to fix. It's something you need to cope with. It's something you need to use to your advantage, not to your disadvantage. Well, thank you everyone for joining the panel today. I want to close out with a quote because, as all three of you know, I like to close my interviews out with quotes. Equity is not about giving everyone the same thing. It's about giving someone what they need to succeed. This quote is by Aristotle. As we close our panel discussion today, I want to return to a simple truth. ADHD is not the source of inequity, the systems are. Somewhere in the world right now is a child with ADHD that has not been recognized yet. Not because he's invisible, but because the system has not understood how to see him yet. What we decide today will decide in the future whether he will see himself as broken or will think that he belongs. The Learning Planet Festival is all about reimagining learning and society, and I think that neurodivergent minds should be included in that. With that in mind, I want to make a few call to actions. If you are an educator, examine your referral and support systems. If you are a clinician, reflect on bias and access. If you are a policymaker, fund equity, not just awareness. And if you are a young person or a parent that's navigating ADHD, Know this, your voice matters, and advocacy changes systems. ADHD does not limit potential, inequity does. I want to thank all of you who joined the panel today, and I want to thank my speakers for volunteering to take time out of their Saturday to be part of this discussion. And I would like if you all could go on YouTube and type in Kirtan 2009. My channel will pop up, and all three of my panelists today have had podcast episodes on the channel. And I deeply recommend subscribing as this will be on there soon as a podcast episode. And also, recently the channel has reached countries such as Philippines, India, and Hong Kong. These are all countries where there are individuals with ADHD that need to hear what is said in these podcast episodes. So if you subscribe, you'll be able to reach many other in the world. Thank you all, and have a great day.
Awesome. Thank you.
Thanks for inviting us.
Good to meet you all.
Bye. Thank you.
Bye now.